Mariam? Good morning, ladies and gentlemen.
Good morning.
We'll start in 2 minutes' time. Once again, good morning, ladies and gentlemen. We're going to continue to look at acyanotic congenital heart disease. The last time we had the lecture, we were looking at left to right shunts, and this time we're looking at obstructive lesions. I think there are about 10 of you here. Is this correct? The obstructive lesions are aortic stenosis or left ventricular outflow tract obstruction, or pulmonary stenosis, right ventricular outflow tract obstruction, and coarctation of the aorta. And these conditions share certain characteristics. They're characterized by increased pressure proximal to the area of obstruction and decreased pressure distal to obstruction. There is hypertrophy of the chamber proximal to the obstructive lesion. And when you compare the gradients, particularly the systolic gradients across the area of obstruction, there is a difference in pressure, and this difference is called the gradient. So the greater the obstruction, the larger will be the gradient. Sorry. We're going to look at coarctation of the aorta first. And this is a narrowing of the aorta opposite the origin of the ductus arteriosus. And there is a male to female preponderance of 2 to 1. And this condition occurs in about 5 to 7% of those conditions called congenital heart defects. And coarctation of the aorta occurs particularly in patients with Turner's syndrome, varying from 20 up to 40% of these patients. 70 to 85% of the patients with coarctation of the aorta will have bicuspid aortic valves. And this is a condition which we're not going to discuss very much in pediatrics, although it is, as I mentioned on the last occasion, it is in fact the commonest acyanotic congenital heart disease. It doesn't usually have much of a clinical significance in the pediatric age group, but has more significance in the adults. If you suspect or find that there's coarctation of the aorta, one should in fact very carefully look for other defects such as mitral incompetence, aortic stenosis, ventricular septal defects, and patent ductus arteriosus. This is an illustration on the left of a normal heart and great vessels, and on the right we see coarctation of the aorta occurring just beyond the origin of the left subclavian artery. And it tends to occur just opposite where the ductus would come out from the aorta. You will look in some of the older textbooks, and they will talk about pre-ductal and post-ductal coarctation. That terminology has gone out of use for the most part, and in fact, it is felt that most of the cases of coarctation of the aorta occur in the area of the origin of the ductus arteriosus. And if you look at this diagram, and in fact it's turned on the side, you will see, in fact, when the ductus is open, for some reason, I'm not able to get my pointer. Are you seeing the pointer? Is the
No, doc.
pointer visible?
No, doc.
I'm really not. Okay, let me try again. Is it visible now? Can you see a pointer or a hand?
No, doc.
Okay, if you look at about the 4 o'clock area, you see PA, which is a pulmonary artery. And at about the 12 o'clock position, you will see coarctation of the aorta. And in fact, when the ductus arteriosus is open, and that connects the pulmonary artery to the aorta, there is a better flow across the obstructed area in the case of coarctation. So blood flows around the obstructed area. Once the ductus arteriosus closes, there's a smaller area for blood to flow across. So coarctation becomes more prominent when the ductus arteriosus closes. So if you compare the previous illustration, you can see, in fact, PA representing the pulmonary artery, and the ductus is constricted there, that dark string, opposite the coarcted area there. So in fact, that there's a decreased flow across the obstructed area once the ductus arteriosus has closed. Coarctation of the aorta is a narrowing of the aorta opposite the ductus. There is hypertension proximal to and hypotension distal to the ductus, and this affects primarily the systolic pressures. There is an increased afterload on the left ventricle. There is a pressure overload. There's increased wall tension causing left ventricular hypertrophy. Would you like to state what type of hypertrophy you would expect in the case of a pressure defect? What are the types of hypertrophy? There's concentric and eccentric. What occurs in the case of a pressure defect? Are you familiar with these terms? Are you familiar with these terms?
Yes, doc.
Yes, so which one would it be in the case of coarctation?
I think concentric.
That's correct. Eccentric is when there's volume overload, and concentric is when there's pressure overload. So there's increase in wall thickness, and unless there is cardiac failure, the internal volume of the ventricle is not increased. The other features in coarctation of the aorta are delay in the femoral pulses when you compare them with the upper limb pulses like the brachial or radial pulses. And the volume of the pulse would be weaker in the lower limbs, in the legs, or in the groin. And in some cases, when the obstruction is severe, it's not possible, in fact, to feel the femoral pulses. And that's a very important aspect of coarctation of the aorta. And if you don't feel the femoral pulses in your examination of the patient, you are likely to miss the fact that the patient has coarctation of the aorta. If you're concerned about and want to have a repeat of what I have said, please indicate. Do you understand that?
Yes, we do.
Very good. The clinical presentation of coarctation of the aorta varies according to the age. If there's severe coarctation, quite often the newborn infant goes into failure shortly after birth or in early infancy, especially if there are other conditions present, such as aortic stenosis or a ventricular septal defect or narrowing of the proximal aorta, of the aorta proximal to the obstruction. This cardiac failure can be very severe and in fact requires aggressive management and often will require surgical management in the newborn period. The other presentation may be that the patient is entirely asymptomatic. But when you examine the patient at any age, you recognize, in fact, that the femoral pulses are abnormal in that they're delayed or weakened or absent. And the other method of presentation, or the other way in which you may detect coarctation of the aorta in an older child or an adult life, is during the investigation for hypertension, or the patient, in fact, may present with complications of hypertension, such as congestive cardiac failure or cerebrovascular accidents. And those are the three ways in which patients tend to present with coarctation of the aorta. On physical examination, there's usually normal growth and development, and there may or may not be evidence of congestive cardiac failure. And as I've put in bold on the slide, they're absent, weak, or delayed femoral pulses. That's the cardinal sign of coarctation of the aorta. And there will be abnormal forelimb blood pressures. What's the abnormality that you would expect in the case of coarctation of the blood pressures? Anybody? Anybody?
Will the pulses be elevated?
Sorry? What did you say? What do you think the blood pressures are going to, when you take the blood pressures in the upper limbs and you compare it with the blood pressures in the lower limbs, what would you expect in a patient with coarctation? And somebody has answered that it would be higher in the upper limbs. Yes, of course, because you get hypertension, particularly systolic hypertension, proximal to the obstructed area, and hypotension beyond the obstructed area. There is evidence of left ventricular hypertrophy. Usually the first sound is loud, and there may be a murmur of a bicuspid aortic valve, which, as mentioned before, occurs in up to about 80% of the individuals with coarctation. Or you may get a continuous murmur in the collateral vessels which develop in order to provide blood flow to the descending aorta. And this is a continuous murmur, which you often hear in the infrascapular area. The investigations when you suspect coarctation will include ECG, and if you remember, it is the dominant ventricle shortly after birth is the right ventricle. So in the newborn period, the ECG may show right ventricular hypertrophy. In later infancy and in the older child, there would be left ventricular hypertrophy. The chest X-ray will show normal or slightly increase in the heart size, normal or slightly enlarged heart, and there may be rib notching in the 4th to 8th ribs, which I will show you shortly, and in patients over 5 years old, the 3 sign. So let me find this X-ray. You see the inferior aspect of the ribs? That's rib notching where collateral vessels come out to provide blood flow across the obstructed area of the aorta. Now this is in the children over 5 years old. This is the 3 sign. And if you look here, which I think you should be able to see, do you see the 3? That's the upper belly of the 3 with a yellow arrow. The blue arrow indicates the area of obstruction in coarctation, and the green arrow, the lower belly. So that's the 3 sign. And that is seen in the upper left mediastinum in children usually over 5 years of age. They are very faint areas here showing indentation of the lower aspect of the ribs. The complications of coarctation are congestive cardiac failure in the newborn and in infancy, and if not aggressively managed in this age group, these patients may perish. Patients with coarctation may develop infective endocarditis, not on the obstructed area, but on the bicuspid aortic valves, which are present in most of these patients. There may also be systemic hypertension and the complications in the child, in the older child, and in adult life. And very rarely, there may be rupture of the proximal aorta in older life. This is not usually a complication which we see in the pediatric age group. The management, there is medical management for congestive cardiac failure and for hypertension. And surgery is really the definitive treatment in children. After operation, There may be persistence of hypertension, which may require drug treatment for a period of time. And in some situations, the area of the operation, there appears to be a recoarctation because the adjacent areas of the aorta grow at a quicker level than the area where the sutures are. So there appears to be a recoarctation. So you need to follow up these patients. If there's recoarctation, we need to treat the patients with balloon angioplasty, which I will describe shortly. Okay, are there any questions on coarctation? Any questions?
No questions.
Okay. We're now going to talk about aortic stenosis as another obstructive lesion in the acyanotic group. This is an illustration of aortic stenosis, which occurs in up to about 7% of patients with congenital heart disease and a significant male preponderance. And the area of stenosis or narrowing may be at the level of the valve, above the valve, or below the valve, so-called valvular supra or subvalvular stenosis. And in this classification is included hypertrophic cardiomyopathy. And the aortic valve may have 1, 2, or 3 cusps. And in the, as you can see in the diagram there, you can see that there's a thickened left ventricle and there is a thick aortic valve with the very narrow opening. And this again is a demonstration of the aortic stenosis. In aortic stenosis, there may be no symptoms, even in severe aortic stenosis. And this is one of the conditions in which a young adult usually can be undertaking quite vigorous physical activity over time, and then on one occasion may suddenly collapse and demise during exercise. So even with aortic stenosis, this may happen. Go ahead, please.
What did you say? It's
I'm not hearing you. There may be no symptoms in even severe aortic stenosis until there's sudden collapse during exercise. You were asking what is HCM is hypertrophic cardiomyopathy. Does that answer? Okay. All right. The symptoms which may be present with aortic stenosis are chest pain, tiredness or syncope in some severe cases, particularly on exercise. And this chest may, in fact, may be anginal in nature, especially when there is stenosis just above the area of the valve. If I go back to the, let's go back to this diagram. If there is supravalvus stenosis, the narrowing occurs beyond the origin of the coronary arteries, which is just above the level of the valve leaflets. So in fact, the increase in blood pressure occurs at the area where the coronary arteries originate. So in fact, the coronary arteries are subject to hypertension and degenerative changes. So there may be anginal chest pain when you have supravalvular aortic stenosis. Tiredness and fainting or near fainting may occur in other cases. And in the case of what we call critical aortic stenosis in newborn and in infancy, the patients are in congestive cardiac failure, which, if not aggressively treated, may result in the death of the patient. On examination, patients with aortic stenosis, with mild cases of aortic stenosis, may have only an ejection systolic murmur at the upper right or upper left sternal edge. And this murmur tends to conduct into the neck. And in some cases, there is an ejection click as well with the murmur. In more significant cases of aortic stenosis, the blood pressure is decreased. And when you feel the pulses and you measure the blood pressures, the blood pressures are low and the pulses are weak. The pulse volume is weak. In the case of severe aortic stenosis, you may get paradoxical splitting of the second sound. And the apex beat would be forceful. Are you familiar with paradoxical splitting of the second sound? Well, before we consider paradoxical splitting of the second sound, tell me about normal splitting of the second sound. Would anyone like to describe or comment on paradoxical splitting of the second sound or normal splitting of the second sound? What happens to the second sound when you take a breath in, when you breathe in? Anybody? What happens to the second sound on inspiration? Let's go back further. What happens to the flow of blood into the right heart on inspiration? Yes, there is increase in the blood flow to the right heart because during inspiration there is increased negative pressure in the right heart. So there's increased flow of blood into the right atrium and right ventricle. And because there's an increased volume of blood in the right ventricle, it takes a longer time for the blood to be ejected across the pulmonary valve. So there is delay in closure of the pulmonary valve, so that in relation to the first sound, the second sound is delayed. And this is what, in fact, every time you auscultate the heart, this is what you will find if you listen carefully, that the splitting of the second sound is greater during inspiration. When there is severe aortic stenosis, it takes a long time for the blood in the left ventricle to go across the aortic valve. And therefore, the closure of the aortic valve is going to occur after closure of the pulmonary valve. So what you will notice, in fact, that during inspiration, the split narrows and does not widen, as is a normal situation with normal splitting of the second sound. So this is what we call paradoxical splitting of the second sound. And this is related to the delay in closure of the aortic valve. Is that clear? Do you need a further explanation or not? Anybody? One more time. Okay. Let's go back to the normal situation. When there is inspiration, there is increase in the negative intrathoracic pressure in the chest. So during inspiration, more blood is drawn into the right side of the heart, into the right and into the right ventricle. So there's a greater volume of blood to be ejected across the pulmonary valve. And this leads to a delay in closure of the pulmonary valve and leads to widening of the split of the second sound. When there is severe aortic stenosis, because of the narrowing of the aortic valve, it takes a longer time for the blood in the left ventricle to be ejected across the aortic valve. Therefore, you will find that during inspiration, the split becomes narrower rather than wider, which is a situation which is a normal situation. So this is what is called paradoxical splitting of the second sound. The apex beat is forceful because there is left ventricular hypertrophy. So this is what you find a prominent, easily located apex beat. And in critical aortic stenosis in infancy, when these patients go into failure, they have a large heart and evidence of cardiac failure. The investigations, if there is mild aortic stenosis, the ECG is going to be normal, and there may be, in the moderate and severe cases of aortic stenosis, evidence of left ventricular hypertrophy with ST and T wave changes in the more severe cases. On the chest X-ray, the heart size is normal, which is the usual finding, and there's concentric hypertrophy. There is hypertrophy of the muscle, but the outer dimension of the chamber, in fact, does not increase. And the echocardiogram will demonstrate the defect, will demonstrate the abnormal flow, and you may be able to calculate the gradient, which is the difference between the systolic pressures proximal to when compared with the systolic pressures beyond the area of obstruction. The management of these patients, dental hygiene, as in all cases with congenital heart defects, dental hygiene should be monitored and maintained. Infective endocarditis prophylaxis is not mandated prior to dental work in the more recent recommendations. And you need to follow up these patients carefully and repeat the investigations. If you have aortic stenosis of moderate and severe levels, the patient should have exercise restriction until the obstruction is relieved surgically or otherwise. Balloon valvuloplasty may be done, and I'll talk about balloon valvuloplasty when we speak about pulmonary stenosis next. And surgery may also be done. There is valvotomy, where you can actually cut into the commissures of the valve and into the valve itself. If the aortic valve is dysplastic, then there may be replacement of the valve. And it's important to follow up these patients post-operatively. For children with hypertrophic cardiomyopathy, we prescribe beta blockers. And for the older children and the adults, sometimes they may actually cut away some of that thick muscle just below the narrowed aortic valve. But surgery is not the main management for patients with hypertrophic cardiomyopathy. Beta blockers are used instead. Any questions about aortic stenosis? Now, in pulmonary stenosis, which accounts for up to 7% of congenital heart defects, the narrowing of the pulmonary, in pulmonary stenosis, you can have narrowing just above the level of the valve, at the level of the valve, or below the level of the valve, as shown in the diagram on the right side of this slide. And in fact, what you will notice is that the right ventricle, which is normally a thinner ventricle than the left side, has become quite thick. Once again, if the defect is mild, the patient is asymptomatic. And this a mild defect will be when there is a gradient of 20 or less across the area of obstruction. In patients with moderate to severe pulmonary stenosis, they may have shortness of breath on exertion. And in the case of critical or severe pulmonary stenosis, when the gradient exceeds 60 millimeters of mercury, the patients may have shortness of breath and congestive cardiac failure, and they may becomes cyanosed, and I will go back to the diagram to try to explain what happens. So when there is severe pulmonary stenosis, right heart failure may occur, and the patients will have the symptoms of exertional dyspnea and the other features of cardiac failure. And the right ventricle, in fact, dilates, and the pressure inside the right ventricle, where that arrow is shown, is increased. And this leads to incompetence of the tricuspid valve. So the right atrium becomes dilated at high pressure. And this causes a widening of the foramen ovale, and it creates a defect between the right atrium and the left atrium. So if you have a right ventricle with high pressures and high volume, you will get a flow from right atrium to left atrium. So what is going to happen to the arterial saturation? Yes, there will be desaturation because you will have deoxygenated blood from the right atrium mixing with oxygenated blood in the left atrium, which has blood coming back from the pulmonary veins. And in fact, this mixing of blood in the left atrium will lead to desaturation in the left ventricle and the aorta, and will lead to cyanosis. So this is a situation with critical pulmonary stenosis where basically a cyanotic lesion may become cyanotic. When you examine these patients, they get a right ventricular type apex beat, and as I mentioned before, the apex beat is felt over a wider area, and the impulse itself, the apex beat impulse, is weakened. And you may have in pulmonary stenosis, the pulmonary second sound may be soft or delayed or absent when you auscultate. And so it will appear single in some instances. In some patients, there is an ejection click during systole, and particularly in patients who have stenosis at the level of the valve, they get an ejection systolic murmur at the upper left sternal edge, and this may be heard in the back as well. Management in pulmonary stenosis. In severe pulmonary stenosis in the children, exercise, we try to restrict exercise. Of course, restricting exercise in small children is not easily accomplished. Medically, infective endocarditis prophylaxis is not routinely required for dental work. And one of the preferred method of managing this condition is to do balloon valvuloplasty. So if we look at this diagram, on the left in A, contrast medium, in fact, has been injected into the right ventricle and goes across a thickened pulmonary valve. And you can see that there is post-stenotic dilatation of the pulmonary artery, which is seen when there is valvular stenosis. In balloon valvuloplasty, a collapsed balloon catheter is introduced into the groin of the patient in the femoral vein and into the IVC, the right atrium, and the right ventricle. And this collapsed balloon catheter is passed across the pulmonary valve. And when it is sitting in the area of the pulmonary valve, is distended with contrast medium. So in fact, it causes a of that stenotic area and decreases the gradient across the narrow pulmonary valve. And this is the way, this is a preferred way of dealing with pulmonary valve stenosis. And it allows you to relieve the obstruction without having to do an incision in the chest. And the patients may go home usually by about 48 hours after the procedure. We don't do this routinely here because on many occasions we don't have the appropriate catheters. And we have, in fact, on occasion sent away small babies to have this procedure done, or the procedure is done by visiting interventional cardiologists. That's balloon valvuloplasty. Surgery can also be done to relieve the obstruction, valvotomy when there's into the valve itself, or resection of thick muscle in the right ventricle below the pulmonary valve, or there may be a patch placed across the outflow tract of the right ventricle. And these patients need to be followed up post-surgery to see if there is recurrence. Are there any questions?
I don't think there are any questions.
We'll have a pause of about 3 minutes, and then we'll continue. And we'll look at cyanotic congenital heart disease. Okay?
Okay, Doc, no problem.
Sorry?
Okay, cool.
Okay. let's talk about cyanotic congenital heart disease. There are a number of terms on these slides, which I think you're probably familiar with. And in your revision, it would be useful for you to revise these terms to increase your understanding of cyanotic heart disease. Percentage oxygen saturation speaks to the proportion of red blood cells which contain oxygen. And the partial pressure of oxygen indicates the availability of oxygen in the alveoli and in the serum. And oxygen dissociation curve shows the relation of oxygen saturation and PO2. The oxygen content may actually be calculated because there is a constant where 1 gram of hemoglobin requires approximately 1.39 mils of oxygen at 100% saturation. So if you know the level of the hemoglobin and the percentage saturation, then you can calculate the oxygen content using the constant of 1.39. So an adult with a hemoglobin of 15 grams at 100% saturation would have an oxygen content of 208 mils of oxygen per liter of blood. Notice in the calculation that we multiply by 10 because this result is expressed per liter of blood, not per deciliter. If you have an adult with a hemoglobin of 15 grams at 70% saturation, that calculation comes out to 146 mils of oxygen per liter of blood. In a newborn, the oxygen content may be calculated using the hemoglobin level, and in the newborn period, the hemoglobin level is usually high, so 20 grams would be a normal hemoglobin in that patient. And at a saturation of 75%, the calculation for the oxygen content would come to 208 mils of oxygen per liter of blood. In a patient in the newborn period with a hemoglobin of 12 grams, which is considered anemic in the newborn period, and a saturation of 6%, that calculation is only 100 mils of oxygen per liter of blood. Cyanosis really means blue blood, and it is a sign, it is not diagnosis. And it usually requires that the patient who's being observed has 5 grams per deciliter of reduced hemoglobin. There are some careful observers who can detect cyanosis when there are 3 grams of reduced hemoglobin on board in the patient. Most observers require 5 grams per deciliter of reduced hemoglobin. And if we look at this figure, it means that if you've got a patient who has a hemoglobin of 10 and is anemic, it's going to take considerable desaturation for you to detect cyanosis in that patient. okay? And in fact, that would probably have a saturation of about 50%. So cyanosis is more difficult to detect when there is anemia. Cyanosis may be peripheral, it may be central or complete, and it may be differential, where you find that one area of the body may be cyanosed and not the other area. And we will talk about this a little later. The causes of cyanosis may be cardiac or pulmonary in origin, and may also be secondary to central nervous system conditions. And in these central nervous system conditions, there is depression of the respiratory center, and these patients are usually comatose. There are other causes, such as hematological causes for cyanosis. And you may recall that some years ago, there were some visiting tourists who, for some reason, obtained, probably accidental, in saltpeter and was using saltpeter, which contains nitrates, to season their food, and they developed this cyanosis. In general, it's mainly cardiac and pulmonary causes for cyanosis which you encounter clinically. In the cyanotic infant, we want to determine, is this cyanosis peripheral or central? And central may be called complete by some workers. So in peripheral cyanosis, the mucous membranes are pink, but the extremities are blue. And the PO2 would be normal, and the extremities are often cool. And one has to differentiate this condition with shock, sepsis, or a cold environment. In central cyanosis, the mucous membranes are blue, and when you do the blood gases, there is a low PO2 and low oxygen saturation. And the patient is often, the extremities are warm. One has to make a decision sometimes as to whether the cyanosis is due to a cardiac cause or a pulmonary cause. In the case of cardiac cyanosis, as happens in a patient with tetralogy of Fallot, which is associated with obstruction to the flow of blood across the right ventricular outflow tract. When the patient cries, there is a Valsalva effect, which reduces the flow of blood into the pulmonary circulation. So there is an increase in crying. There's an increase in cyanosis when the patient cries. And we will look at this during tetralogy of Fallot. There may or may not be shortness of breath, and quite often with a cardiac cause for cyanosis, there will be a normal ECG, and the X-ray, the chest X-ray, will show changes. For example, if there is obstruction to the flow of blood out of the right ventricle, as occurs in patients with tetralogy of Fallot, you will notice that the pulmonary vascular markings are decreased. The PCO2 is normal, and there is a small response when you give these patients 100% oxygen. The patients who have a pulmonary cause for cyanosis are usually in respiratory distress. The ECG may be normal or is usually normal, and the chest X-ray will show the changes because of the primarily pulmonary lesion. And there is, in fact, respiratory acidosis with increase in the PCO2. And when you administer 100% oxygen to these patients, there is a marked response. And quite often the PO2 will go above 200. The studies which are done in patients with cyanosis are pulse oximetry, which in most places a routine observation. And if you give the patient 100% oxygen, when there is a pulmonary cause and there's hypoventilation, for example, if there's a large pleural effusion, then you will notice, in fact, that the PO2 will increase to over 200. If there's a right to left shunt, as occurs in a patient with tetralogy of Fallot, it is unlikely for the PO2 to increase above 100. And when there is a mixed picture of pulmonary disease and cardiac failure, then on administering 100% oxygen, the PO2 will go to between 100 and 200. Nowadays, we don't use dextrose sticks, which to measure the blood glucose. We use a blood sample and measure the blood glucose, or we use a glucometer, but it should be noted, in fact, particularly in the newborns, that the GMR is not accurate at high or low levels of sugar. Urea and electrolytes would also be done, and the hemoglobin and hematocrit would be indicated in these patients with cyanosis. A chest X-ray would be required, as well as an ECG and an echocardiogram. You can classify cyanotic congenital heart disease according to the pulmonary blood flow. There are conditions in which there is cyanosis with increased pulmonary blood flow. For example, transposition of the great arteries, which we will talk about a little later, or total anomalous pulmonary venous return, or a condition called truncus arteriosus, in which the outflow from the right ventricle and from the left ventricle mix in a common trunk, which gives rise to the aorta and to the pulmonary artery. And there are conditions in which there is decreased pulmonary blood flow, such as tetralogy of Fallot, pulmonary atresia, and tricuspid atresia. It's important for you to note that whereas transposition of the great arteries is the commonest reason for cyanosis to occur in the newborn period, it is in fact not the commonest cyanotic congenital heart disease in general. Tetralogy of Fallot is the commonest cyanotic congenital heart disease at all ages, but tetralogy of Fallot patients are not usually cyanosed at birth unless the defect is very severe. Are there any questions?
Hi, morning, doc. What does TAPVR mean again?
Okay. Total anomalous pulmonary venous return. So it means that the oxygenated blood flowing from the pulmonary vessels and the pulmonary circulation would not return via the pulmonary veins into the left atrium, but would usually return to the right atrium or the right side of the heart. So what you would get, and I'll talk about this and illustrate it a little later. In fact, what you have is oxygenated blood coming back from the pulmonary veins, mixing with deoxygenated blood in the right atrium, and the patient is cyanosed. Any other questions? We'll come back to the types of cyanotic congenital heart disease a little later. The complications of cyanotic congenital heart disease are polycythemia, and there are some authorities which prefer to use the term erythrocytosis, which refers to increase in the level of the red blood cells, rather than using polycythemia, which implies that you have increase in red cells, white cells, and platelets. But loosely, polycythemia is still used to describe that clinical feature. Thrombosis is also a complication because the hemoglobin and hematocrit increase, and the viscosity of the blood is increased and predisposes to thrombosis. Paradoxical emboli may also occur, and many of these cyanotic congenital heart defects, in many of these cyanotic congenital heart defects, the blood in fact will bypass the pulmonary circulation. And in fact, and when we come to tetralogy of Fallot, we see it. So that emboli, which might be in the systemic venous blood, instead of going into the pulmonary circulation, in fact will bypass the pulmonary circulation, where these emboli, whether infected or thrombotic emboli, would be removed and go straight into the cerebral vessels. So these emboli predispose the patient to obstruction of the cerebral blood supply and strokes and cerebrovascular accidents, and also predisposes to brain abscesses because infected emboli will not be removed in the pulmonary circulation. Patients with cyanotic congenital heart disease also are at risk, significantly at risk for infective endocarditis. And in about 2007, the American Heart Association and the American Dental Association put out some recommendations which state that cyanotic congenital heart disease patients should receive treatment with antibiotics prior to dental procedures because of their increased risk of developing infective endocarditis. So any patient who has a cyanotic congenital heart disease who needs dental work will require antibiotic prophylaxis prior to the dental work. Other conditions requiring antibiotic prophylaxis prior to dental work are conditions or patients who have prosthetic valves or prosthetic material in the heart and great vessels. Now we're going to talk about tetralogy of Fallot. Are there any questions about cyanotic congenital heart disease? Well, if no questions are present, let's get on with tetralogy of Fallot. And there are four components to tetralogy of Fallot: a ventricular septal defect, obstruction of the right ventricular outflow tract, hypertrophy of the right ventricle, and overriding of the aorta. So when we look at this diagram here, you'll notice, in fact, that the right ventricle is thickened, and the right ventricle, in fact, is contracting against increased pressures in the aorta. You will notice that there is narrowing at the level of the pulmonary valve, and there's thickening of the muscle just below the pulmonary valve, and that's a right ventricular outflow tract obstruction, which may also extend to narrowing of the main pulmonary artery and its branches. There is as well an overriding of the aorta, which means that the origin of the aorta overrides the ventricular septum and the ventricular septal defect. And in this case, in this diagram here, we can see that there is an arrow showing the flow of blood from the right ventricle into the left ventricle in tetralogy of Fallot, because this there is a large ventricular septal defect, and which facilitates the flow of blood from the right ventricle into the left ventricle and into the ascending aorta. So that's a right to left shunt, which will cause the patient to become cyanosed. Just to go back to the embryology, most of us don't like embryology very much, but if we look at this diagram here, it will help to explain. In the embryology, in tetralogy of Fallot, there is anterior and superior displacement of the conus septum, which results in a non-alignment VSD in the area of the membranous septum. So let's go to these drawings. In the top three figures, which is a normal situation, you see the conus septum coming down from above and the trabecular septum arising inferiorly. And in normal embryology, the conus septum from above grows and meets the trabecular septum, and they fuse and form a complete wall between the right ventricle anteriorly and the left ventricle. In the case of tetralogy of Fallot, the conus septum, which is that white line from above, does not grow to meet the trabecular septum from below. And in fact, the conus septum is displaced anteriorly, which is to the left, and superiorly. So there is a defect in the septum. And that is what happens in the embryology of tetralogy of Fallot. The hemodynamics involve large unrestricted VSD. So they usually have a large ventricular septal defect. And at cardiac catheter, when you measure the aortic pressures and the pressures in the systolic pressures in the right ventricle, in the left ventricle, and in the aorta, the systolic pressures are the same, and that's characteristic. So in fact, the right ventricle, which would normally eject blood against a low pressure in the pulmonary circulation, is ejecting blood against high pressures with systolic pressures equal to that in the aorta. The obstruction of the right ventricular outflow tract may be at the level of the infundibulum, which is that part of the right ventricle just below the pulmonary valve, or it may be at the level of the valve, or at the level of the pulmonary artery and branches. There is a right to left shunt through the ventricular septal defect to the aorta. And when you look at the pulmonary vascular markings on the chest X-ray, the pulmonary vascular markings are decreased because of the obstruction to the flow of blood into the pulmonary artery. The clinical features include being pink at birth unless the defect is severe. So this is not usually discovered at birth unless you have a lot of narrowing of the outflow tract of the right ventricle, or you have a lot of narrowing at the area of the pulmonary valve. And quite often these patients will present with a murmur which is very similar to the pansystolic murmur which is heard in the ventricular septal defects. And that is what you notice first. Then after a few weeks and sometimes months of life, these patients are observed to go blue on crying, because when there is crying, there is a greater obstruction to the flow of blood into the pulmonary circulation. So there's a greater flow of deoxygenated blood from the right ventricle going across the ventricular septal defect into the left ventricle and into the aorta. And then over time, it is observed that the patients become persistently cyanosed all the time, and they develop clubbing of the fingers and toes. They also exhibit shortness of breath on exercise, and they're observed to do squatting. Are any of you familiar with squatting or have an idea how it works? If you squat, what happens? Go ahead. If you squat, what happens to the resistance in the femoral?
Is it that it would increase the systemic vascular resistance?
Yes, it would increase the systemic vascular resistance. And what is going to happen to the flow of blood coming back from those large muscles in the thighs and the lower limbs?
They
If you
would
take
decrease.
the femoral vein, what happens? The flow of blood is going to decrease. So having assumed the squatting position, you're reducing the systemic vascular resistance, which will increase the flow. What will the systemic vascular resistance do to blood flow across the ventricular septal defect? Is it going to increase the flow of blood from right ventricle to left ventricle, or is it going to decrease it? If you increase the systemic vascular resistance, yes. So if they are in the systemic circulation, you increase the vascular resistance, it's going to reduce the flow of blood from the right ventricle across the defect into the left ventricle. So the patient will become less cyanosed. Agreed?
Yes, doc.
Okay. What is the effect of reducing the volume of blood going back into the right ventricle, right atrium and right ventricle? What is that going to do with the flow of blood across the ventricular septal defect? Is it going to, it would decrease, yes, it would decrease the flow of blood from right to left. So the kinking of the femoral artery and kinking of the femoral vein both have the effect of reducing the right to left shunt and reducing the cyanosis. And these small children learn that when they do the squatting, they feel better. So they will exercise and then they will squat. And in fact, sometimes when they get admitted to hospital, they assume the squatting position even in the cot. Everybody got the squatting okay? Would you like to say that? Would you like to go through that again? Just a moment, please, just a moment. Okay. Okay. All right, so the squatting will reduce the right to left shunt and decrease the cyanosis. Once these patients become cyanosed, there is decrease in growth and there is development is delayed. They are also prone to developing hypercyanotic spells. Are you okay with the explanation so far, or do you want to go over the effect of squatting? Are you okay with that, or do you want it to be repeated? Repeat, please. Okay, let's go back. I really have to apologize for the pointer not showing up. Let me go back to a diagram, which might make it easier. Okay. During having assumed this squatting position, there is what happens to the systemic vascular resistance. If you kink the femoral artery, what happens to the systemic vascular resistance? Is it increased or decreased? Anybody? Are you there? Kinking of the femoral artery increases the systemic vascular resistance. Increases systemic vascular resistance. So if you look at the diagram on the screen, you will see, in fact, that there's going to be a reduction in the flow of blood from the right ventricle to the left ventricle if you increase the systemic vascular resistance, which means that the oxygenation is going to improve if you have less of a right to left shunt. When there is kinking of the femoral vein, there is reduction in the blood flow from those thick muscles in the lower limbs. So there's decreased volume of blood coming back into the right ventricle. And if there's decreased volume of blood in the right ventricle, that's going to reduce the volume of blood flowing from right ventricle to left ventricle, and it will decrease the right to left shunt. So kinking the femoral artery and kinking the femoral vein will reduce the right to left shunt and improve the oxygen saturation. Okay, any questions? Are you all right with that?
Yes, Doc, thank you.
Anybody not all right? Obviously, there is nobody not all right. Okay. Now let's talk about blue spells and their synonyms. They're also called TED spells, hypercyanotic spells, and if we look at the diagram in front of us, on the left-hand side, we have a patient with tetralogy of Fallot with obstruction at the level of the pulmonary valve there. And you see those two thick muscles just below the pulmonary valve, which also cause obstruction to the outflow tract of the right ventricle. And then we have the curved arrow across the ventricular septal defect. And in this patient, this is a cyanosed tetralogy of Fallot patient. Under certain conditions, they get hypercyanotic spells, where for some reason there is an increase in the flow of blood from the right ventricle across the ventricular septal defect into the left ventricle. And you will see that there's increased cyanosis in the ascending aorta and the arch of the aorta. And the conditions, in fact, which will cause that is if there is a sudden decrease in the systemic vascular resistance, which will promote the flow of blood from right to left, or if there is contraction of that thick muscle below the pulmonary valve, which we call the infundibulum muscle. And this muscle is under sympathetic nervous system control. So when there's stimulation of the sympathetic nervous system, that muscle contracts, and it further reduces the area for blood to flow from the right ventricle into the pulmonary artery across the pulmonary valve. So this is a hypercyanotic. This is what happens in hypercyanotic spells. It's also called an infundibular spasm because of the spasm of that muscle below the pulmonary valve. And what you will notice in the patient is that the patient, and usually it's a small child, the child will start to cry and you're unable to console the child. And then what you will notice, in fact, is that the child becomes increasingly blue. The periphery and centrally, the child becomes increasingly cyanosed. And in some cases, when the blue spell is severe and the right to left shunt is markedly increased, these patients, because of cerebral anoxia or hypoxia, will faint. They become unconscious, or they have a seizure, or if there's a severe and prolonged blue spell, they may actually perish. The other thing that you will notice is that these patients breathe very fast. And this is because of the stimulation of the respiratory center, because of the low oxygen and the high bicarbonate levels. These patients will begin to hyperventilate, which is not a good thing in a blue spell, because the more they hyperventilate, the more blood is going to be drawn into the right ventricle. And the greater the right to left shunt. Excuse me. Hello. I'm teaching. Okay. All right. So there's hyperventilation, which increases the right to left shunt, which is not the appropriate thing in a blue spell, because it's going to increase the volume of blood going into the right side of the heart. Do you understand the blue spell, or shall I go over it?
Can you do it one more time, though?
Okay. With the blue spell, also called the Tet spell or the infundibular spasm, or for some reason, there is increase in the volume of blood flowing from the right ventricle to the left ventricle. And if you look in the diagrams in front of you, you will see that thicker arrow from the right ventricle across the ventricular septal defect into the left ventricle. So when you increase the volume of blood flowing across there, then the patient is going to become increasingly cyanosed. What will increase that right to left shunt significantly is if there is a situation where the systemic vascular resistance falls. if the systemic vascular resistance falls, then it causes more blood to be ejected across the VSD into the left ventricle. The other condition which will increase the right to left shunt is increasing the obstruction to the flow of blood across the pulmonary valve into the pulmonary circulation. And this happens when you notice that those two muscles, that muscle below the pulmonary valve it contracts, and it causes a further obstruction to the flow of blood across the pulmonary valve. So conditions which promote the right to left shunt may lead to a blue spell. And during the blue spell, what you will notice is that the patient, usually as an infant or a small child, will begin to cry inconsolably, and they will get short of breath, and they will become increasingly cyanosed. And in some instances, if there's a severe blue spell which is prolonged, then the patient might lose consciousness because of cerebral hypoxia, or they may have a seizure, or in some instances they may get damage to the brain, and in some instances they perish if the hypoxic spell is prolonged. That's a blue spell. The physical examination, the classical features, generally, once a patient becomes cyanosed, the growth is impaired, and they have central or complete cyanosis and clubbing of the fingers and toes. The pulses and the blood pressure are normal, and the heart itself, there's a quiet precordium. There's a diffuse tapping apex beat because of the right ventricular hypertrophy. There's a right ventricular heave, a parasternal heave. The second sound is single because the pulmonary component is absent or very soft. And the typical murmur which they have is an ejection systolic murmur at the upper left sternal edge in the area of the pulmonary artery. These patients do not go into cardiac failure unless there's been some surgical intervention or there is a condition which exists in addition to the tetralogy of Fallot. The investigations will show hemoglobin and hematocrit being increased because the hypoxia stimulates the production of red blood cells in the bone marrow. The pulse oximetry will show the readings lower, usually lower than 93. And during a blue spell, in fact, these readings become even lower. The ECG will show right axis deviation and right ventricular hypertrophy. The heart size is usually normal. And when in fact you look at the lung markings, there's decrease in the pulmonary blood flow. This is the typical boot-shaped heart of tetralogy of Fallot. You notice, in fact, that the cardiothoracic ratio is normal, and the lung fields show decreased pulmonary vascular markings so that the lung fields appear dark. And in this patient, we see, in fact, that the apex of the heart is upturned because the right ventricle is an anterior and inferior chamber. So when it hypertrophies, it tends to tilt up the apex of the heart. And in this particular patient, you will notice that the aortic arch is going on down on the right side of the vertebral column rather than on the left side. And in fact, about 25% of the patients with tetralogy of Fallot have a right aortic arch. And you will notice a hollow in the area of the pulmonary artery, which gives the appearance of a boot-shaped heart. The echocardiogram will show all the features of tetralogy of Fallot. There is usually no need to do a cardiac catheter nowadays prior to surgery. A good echocardiogram will give the surgeon all the information which is necessary. The management of tetralogy of Fallot, it's very important in these patients to maintain the hydration, because once the patient becomes dehydrated, it means that the hematocrit is going to increase and the hemoglobin is going to increase and the viscosity of the blood will increase and predispose to thrombosis. So when you're managing patients who are cyanosed or tetralogy of Fallot patients, you have to maintain hydration so that conditions such as gastroenteritis or other conditions with increased output of fluid or decreased intake of fluid have to be managed very aggressively. And sometimes it will lead to hospitalization of tetralogy of Fallot patients, mainly because of this problem. You need to treat iron deficiency. The iron deficiency will cause a stimulation of red cell production in the bone marrow. So if the patient is cyanosed and iron deficiency, that's going to cause an increased production of red cells. So the hemoglobin and the hematocrit will increase, and in fact, the viscosity of the blood will also increase. Sometimes we have to manage patients with cyanotic conditions medically, either because the parents refuse further surgery or it might be an inoperable situation. And it's important to keep an eye on the hemoglobin and the hematocrit. And if the hematocrit is going over 65, or if there is hyperviscosity syndrome, where the patient exhibits increasing tiredness and headache and lethargy, we have to do phlebotomies if the hematocrit is going over 65 or there's a hyperviscosity syndrome. And the management of tetralogy also involves the anticipation and management of blue spells. So once we diagnose tetralogy of Fallot, we make the patient's parents or guardians aware that there may be a blue spell, and we describe it and say that if this occurs, then what you need to do is to hold the patient over the shoulder and put the patient in the knee-chest position. And the knee-chest position mimics the squatting position. And in this case, it reduces the right to left shunt and reduces the desaturation. And if there is a persistence of the blue spell, especially if there are any central nervous system problems, they should seek emergency medical treatment as soon as possible. When these patients get blue spells in hospitals, we will notice sometimes that the medical and nursing staff try to put on oxygen to give oxygen, but oxygen is not helpful in a blue spell because it's not a ventilation problem. It is, in fact, a perfusion problem, and oxygen doesn't really help very much. The management in hospital in a patient having a blue spell is to give a bolus of normal saline or Hartmann solution and give intravenous propranolol, which will reduce the contraction of that muscle below the pulmonary valve and reduce the right to left shunt. In addition, we give intravenous morphine, which is proposed to act at the level of the respiratory center and reduces the hyperventilation which occurs in the blue spell. If they have been in a blue spell for many minutes, then they may become acidotic, and in that case you give sodium bicarbonate intravenously, and you may also use an adrenergic drug such as phenylephrine to increase the systemic vascular resistance. Anticipation of the blue spell when you diagnose this condition is to put the patients on propranolol. If they're having blue spells, you place them on propranolol, and usually that is given about 3 times for the day. And it's a beta blocker, which in fact reduces the contraction of that muscle below the pulmonary valve, and it reduces or decreases the severity of the blue spells. If you have a patient in hospital who has come in as an emergency or has a severe blue spell on the ward, and your various actions have not resulted in decreasing the blue spell and decreasing the cyanosis, you anesthetize and you ventilate the patient, and you go for urgent surgery. And we'll talk about urgent surgery next. You may do a shunt procedure. And in fact, what is done is a Blaylock Taussig shunt, in which the left subclavian artery is divided and the end of it is anastomosed to the side of the pulmonary artery, more frequently the left or sometimes the right pulmonary artery. So what you're in fact doing is increasing the perfusion of the pulmonary circulation when you do that shunt procedure. And that usually abolishes or significantly reduces the blue spells. This procedure may also be done when the patient has very small pulmonary arteries and pulmonary artery branches. It will increase the volume of blood going into the pulmonary arteries and increase the size of the pulmonary arteries so that it would be safe for total correction to be done. Sometimes instead of dividing the subclavian artery, a shunt is placed, or a graft is placed between the subclavian artery and the pulmonary artery on that side. And that's what we call a modified Blalock-Taussig shunt. Total correction, if we look at these three pictures here, in A, there has been an incision into the right ventricle and outflow tract. And we see that there is infundibular stenosis, or that muscle hypertrophy below the pulmonary valve. And we notice that black area looking through the incision, which in fact is a ventricular septal defect. And at surgery, what is done, that thick muscle below the pulmonary valve is cut away. Some of it is cut away, and a patch is placed over the ventricular septal defect. So you no longer see that black object in A. And in some instances, a patch is also placed across the outflow tract of the right ventricle to increase the flow of blood into the pulmonary artery and across the pulmonary valve. So that would be total correction, which is what is aimed for. The complications of tetralogy of Fallot are polycythemia, infective endocarditis, hypercyanotic spells, failure to thrive, brain abscesses, seizures, and cerebrovascular accidents. And any patient with significant polycythemia or erythrocytosis may have bleeding disorders, so it's important to investigate the PTT as well as the platelets. They also have decreased development and may suffer death or brain damage in a severe blue spell, and their complications which may come after surgical correction. Are there any questions? What I'm going to do now, I'm going to wait a while to see if there are any questions. If you have questions and you would like to ask me by email, I'll be happy to try and answer for you. My email address is doreenmillard@yahoo.com. doreenmillard@yahoo.com. And this is an invitation for you if you would like further explanation.
Doc, one question.
Sure.
You keep saying that the beta blockers, the propranolol, it's given to decrease the contraction of the muscle below the pulmonary valve, right? The
Yes.
muscle you're referring to, is that just the right ventricle hypertrophy? Is that what you're referring to?
If you look at this diagram here, you see those two knobs of tissue?
Yes.
In fact, it's the outflow tract of the right ventricle, and you get hypertrophy of that muscle in that area, which is under the sympathetic nervous system control. So when you give beta blockers to the patient, it reduces the contraction of that muscle and reduces one of the areas of obstruction to the flow of blood out of the right ventricle. Does that help you?
Yes, that's clear now. Thank you, Doc.
Okay, anybody else? I think we've come to 12:33, and we have two more. I think we have two more lectures tomorrow. These lectures that we did today, in fact, were makeup for what happened in the first lecture where there was a geographical problem. Any questions?
Hi, Doc. You said it is doreen.millard@yahoo.com?
No, Doreen Millard. Doreen Millard at yahoo.com.
Oh, so there's no dot.
No dot between Doreen and Millard.
Okay,
Doreen
thank you.
Millard at yahoo.com.
Okay, thank you, Doc.
Okay, so I'm through unless there are any other questions. And tomorrow what we would do is go over transposition of the great arteries, talk about cardiac failure, and look at rheumatic fever and rheumatic heart disease. So if you have the time, you could do some reading prior to the lecture. Okay then.
Thank you, Doc.
Welcome. Okay.
Oh, Doc, also, don't, if you can remember to stop the recording, please.
I think I have. I think I have. Have it there?
No, I think I'm